السلام عليكم.
وعليكم السلام ورحمة الله.
Good afternoon, everyone, and welcome to our academic activity for today. So today we have two lectures. We'll start with the pre-operative assessment of patients with congenital heart disease. Will be presented by Dr. Abdullah Shehri and followed by cardiopulmonary bypass in pediatric patients by Dr. Ahmed Al-Ghamdi. We are glad to have Dr. Thomas Matthew with us today for mentoring these two sessions. He's a cardiac surgeon at Prince Sultan Cardiac Center. So we'll start in 5 minutes, inshallah. So I would like again to welcome Dr. Thomas Matthew, who kindly joined us for today. Welcome, Dr. Thomas, and Abdullah, you can start.
Okay, good afternoon, everyone. Is the voice clear?
Yes.
Okay, today we will talk, inshallah, about the pre-operative assessment of patient with congenital heart diseases. So first, our outlines will be history and physical examination for the patient, the most important investigation, and we will have like an outlines for general or the main principles of pre-operative treatments and importance of prostaglandin in congenital heart disease, and we will end with take-home message.
Abdullah,
Sorry?
can you make the slides in view mode?
Sure. Sorry for that. Okay, firstly, as a key facts, the pre-operative assessment of the pediatric or the congenital heart diseases should be a comprehensive approach, should be reviewed by the surgeon, pediatric cardiologist, pediatrician, intensivist, neonatologist, even the anesthesia team, and as well the nurses. All should involved in the pre-op review of these complex patients. And this is usually done, or the discussion done in a formalized meeting is the cardiothoracic meeting. First, history and physical examination. Usually by the time of admission for any elective surgery, usually the diagnosis and treatment plan are usually well established. The cardiac history and clinical physical findings should be reviewed multiple times because any change in the severity may alter the operative and anesthetic strategy. Other non-cardiac anomalies should be addressed because it may alter the management, and this anomalies appear in up to a quarter of the patient with congenital heart disease. Also, acute non-cardiac pathology that might affect the timing of the surgery should be addressed and reviewed. As a background in the history and physical examination for the patients, we should have the primary cardiac condition, the age of the patient, sex, and gestational of the child. As we all know, for symptoms, as a typical in cardiac or congenital heart disease, it's present and become manifest at different times in early life. And this is one of the most important things is the early phase when the BDA or patent ductal arteriosus closes for all ductal dependent cardiac defects. After that, might the patient present. And another important phase or the next important time frame or phase of clinical manifestation is the reduction in pulmonary vascular resistance. So these patients or this kind of congenital heart disease has a different time frame from presentation, from early in neonatal period to late in childhood. One of the most important symptoms my patient present with is, especially in the neonate, is heart failure symptoms or even severe heart failure symptoms and cardiogenic shock. Other important symptoms is cyanosis, pallor, failure to feed or failure to thrive, fatigue, poor exercise tolerance in more older children, shortness of breath, recurrent chest infection, and syncopal attack. Also, we have to address the history of presenting compliance in more details We have to ask about any coexisting medical conditions, any previous intervention, either surgery or percutaneous. And we have to have a summary of known anomalies with any relevant important investigation. Also, we have to ask more deep in previous medical history regarding to any BICU or pediatric admission, history of meconium aspiration, pneumothorax, recurrent chest infection, upper respiratory tract infection, COVID-19 infection, respiratory syncytial virus, or if the child has asthma. Also, from the medical history, important to ask about history of intestinal malrotation, herniation, intestinal atresia, and necrotizing enterocolitis. And if there is known or history of asplenia and athymia, vitamin K deficiency, metabolic diseases, and any exposure to any type of infection, or if the child has any type of allergies, and the important current medications. Signs, we have to look for any dysmorphic or syndromic feature, small for age. We have to look for the color, cyanosis, pallor, clubbing, mottled skin, and any peripheral edema. We have to look to the heart rate and rhythm, any blood pressure discrepancy between the upper and lower limb, any radiofemoral delay, reduced femoral pulses, and upper limb hypertension. Also, we have to examine the jugular venous pressure, if increased or not, hepatomegaly, if there is hepatomegaly, ascites, any added heart sounds or murmur. As well, if there is any tachypnea, tracheal tug, or wheeze or crackles. Investigation, usually we'll start with the basic laboratory. We have laboratory and imaging. We will start with basics. Laboratory investigation like in a CBC, looking for the hemoglobin level, platelets, and also we will have to do a coagulation profile. We will do for the patient renal and hepatic profile, glucose level, urine analysis, blood group and cross match. All of these are important basic metabolic, basic laboratory investigation. Also, we have to do blood gas. Blood gas, it's very important because most of the patients with severe heart failure has metabolic acidosis, which is a typical finding in those kind of situations. Also, we have to look or measure the lactate, which is considered as a surrogate of cardiac output and tissue perfusion. Also, we have to have a baseline ECG, chest X-ray, BE and BA and lateral views, and we have to do echo. Echo is considered the main diagnostic tool for congenital heart disease. Even newborns, all newborns with suspected congenital heart disease should have a neonatal screening for congenital heart defects immediately after birth and 12 hours later. Also, some cases we need to do cardiac cath, angiography, or MRI. Here's some classification for the classification for congenital heart disease. We divide into 5 groups. The first group is the cardiac defect with ductal dependent systemic circulation. And this is usually with left heart obstruction, like a critical aortic stenosis, hypoplastic left heart syndrome, interrupted aortic arch, or critical coarctation of the aorta. Another important classification is cardiac defect with ductal dependent pulmonary circulation, and this is usually with the right-sided obstruction. For example, critical pulmonary stenosis, pulmonary atresia with intact ventricular septum, pulmonary atresia with VSD, more severe form of tetralogy of Fallot, severe Epstein anomalies, tricuspid atresia with pulmonary atresia, or even high-grade pulmonary stenosis. Another group is cardiac defect with parallel circulation, for example, transposition of the great arteries. Cardiac defect with another group is cardiac defects with complete intracardiac mixing, like univentricular hearts and total anomalous pulmonary venous drainage. The last group is cardiac defect with large left-to-right shunt, and this group usually present or became symptomatic and manifest after 4 to 6 weeks from birth. For example, large VSD, complete AV canal, large PDA, orthopulmonary window, truncus arteriosus, univentricular hearts with unobstructed pulmonary blood flow. Here's one or main principle or the basic principle of pre-op treatment of the situation depending on the group. For example, the first group, ductal dependent systemic circulation, like critical aortic stenosis or hypoplastic left heart syndrome. This is the main principle of treatment. We have to stabilize, trying to more stabilize the patient before going to the surgery to improve the outcomes. The first thing, one of the most important thing in the principle is to maintain the patency of the ductus arteriosus. And usually this is done with continuous prostaglandin infusion. The second important concept or principle is to lower the systemic vascular resistance. And the third one is increasing the pulmonary vascular resistance and the pulmonary pressure. And this will lead to increase the blood flow to the systemic circulation. And how we can lower the systemic vascular resistance? We can by reducing the afterload, like with sodium nitroprusside infusion. We can use catecholamine, or if needed, the catecholamine. We try to use the Merinone and or dobutamine because it has a vasodilative effect. And trying to avoid the vasoconstrictive effects of other catecholamines like dopamine and norepinephrine. All of these factors can lead to decreasing the systemic vascular resistance. Another important principle is to enhance or increase the pulmonary vascular resistance and pulmonary pressure by trying to avoid the intubation. And if the patient intubated, try to extubate early, avoid additional oxygen, aiming for mild metabolic acidosis and mild hypoventilation. All of these factors will lead to increased pulmonary vascular resistance, decrease systemic vascular resistance, and enhance the systemic perfusion. The second group, the ductal dependent pulmonary circulation, also we have to secure or maintain the patency of the ductus arteriosus with a prostaglandin infusion. Now we will do the opposite. We will trying or aiming to lower the pulmonary vascular resistance and increasing the systemic vascular resistance, aiming to enhance the pulmonary circulation. So we can lower the pulmonary resistance by aiming for mild metabolic alkalosis, trying to adjust the ventilation for mild hyperventilation, and increase the FiO2 supplement. We can increase the systemic vascular resistance and support systemic pressure by norepi infusion if required. And sometimes we can use an epinephrine infusion and using more volume. In parallel circulation, like TGA, so there is a parallel connection of the pulmonary and systemic circulation. In this kind or in this group, the survival is only possible if shunts between the two circulatory systems do exist. The most important shunt is PFO or ASD at the atrial level. Also, the BDA has a favorable effect on oxygenation. Why? Because the BDA blood flow increases the lung perfusion, and as a result, the volume load and pressure in the left atrium is increased. Thus, or eventually will lead to increase the shunt from left to right at the atrial level. And this will lead to more oxygenated blood can reach to the systemic circulation. Oxygen application or oxygen supplementation may act indirectly by reducing the pulmonary resistance and thus increasing the pulmonary perfusion and increasing left. This will lead to increase blood return through to the left atrium, and this will lead to increase the volume load and pressure, and thus or eventually leading to the increasing shunt from left to right, and thus more oxygenated blood to the systemic circulation. And we have to be cautious with oxygen administration, because uncontrolled administration of oxygen can lead to the closure of the ductus arteriosus when used without prostaglandin infusion. So this was where most important principle in trying to managing or stabilizing a patient with congenital heart disease as a pre-op to decrease the timing or the urgency of the surgery and proper preparing the patient for the intervention. Here the importance, because the importance of the prostaglandin, especially in congenital heart disease and neonate especially, we will address some important points about prostaglandin. Usually it's given to maintain the patency or reopen the ductus in neonate with ductal dependent defect. And due to its short half-life, it must be administered continuously. And we have to know the most common side effects associated with prostaglandin, which are apnea, bradycardia, vasodilatation, effect on pulmonary or systemic circulation, hypotension, fever, edema, and on long-term administration, might patient get cortical hyperostosis or periostitis. Then the day before or the few days before the surgery, we have to order blood and products. In neonate, we usually order 2 units of packed RBCs. Infants and children, usually we order 3 units packed, 2 to 3 units packed RBCs, 2 units platelets, 2 units FFP, and 2 units of cryo precipitate. Medication, pre-operative cardiac medication is not given on the day of the surgery. Vitamin K might be given in infants with coagulation abnormalities as needed. Antibiotics usually give cefazolin 33 milligram per kg IV pre-op, or if MRSA positive or penicillin allergy, we can give the patient vancomycin 40 milligram per kg IV. Patient should be in PO. We have to stop solid or milk 6 hours, breast milk 4 hours, clear fluids 2 hours before the surgery. And we have to start the patient on the IV maintenance IV fluids, and should be given even if the oral fluid is or are withheld more than 4 hours. The consent for most procedure, the parent will have had the opportunity for discussing the option, risk, and benefits of the surgery with the surgeon. Signing the consent from the night before surgery should therefore be a chance to review the important issues. Any other thing adjacent to the surgery, like if needed to be ordered in advance, like homograft, what type and what size, synthetic conduit, what size, if valved or unvalved, all of these things that's required to be ordered in advance should be ordered early. The last thing is the take-home message. So perfect pre-op evaluation and stabilization of the patient will lead to improve the outcomes. These congenital diseases require clear explanation with parents for the short and long-term outcome. Try to clearly explain the nature of the heart disease for the parents and clearly explain the nature of the surgery. And also provide to the family the main goals of the surgery. Thank you for your attention. Any question?
Excellent summary, Dr. Abdullah. Thank you. No questions.
Anytime.
Thank you, Abdullah, for that good presentation. I'm Dr. Thomas. Does anybody else have any questions from the audience? If not, I can, take a discussion forward. Anyone else?
Yes, I have a question.
Okay.
So, if we will take a patient with borderline pulmonary hypertension for Fontaine procedure or a Glenn procedure.
Okay.
Yeah. What can we do other than the routine preparation for the patient to decrease the risk of having
a Fontaine failure?
Yeah.
So it's a bit out of the topic from what we discussed today. It's more today what we discussed, what Abdullah had presented was about mostly about a critical neonate. So that's anyway, to answer your question, ideally we should not take up a patient with a borderline pulmonary vascular resistance for Fontaine, because it's not the best outcome in the long run. But nevertheless, if you have to take up a patient with, say, an elevated PVR, one of the things that intraoperatively we can do is to make sure you don't have any residual lesions like a systemic AV valve regurgitation, or you don't have any other lung pathology associated with it. And surgically, what is mandatory would be to add a fenestration to the Fontaine circuit. And definitely in the preoperative evaluation, you should check for, you do your cath properly, make sure that you don't have a high LVDP or the systemic ventricular EDP. You don't have any extracardiac causes of pulmonary hypertension, like say an endocrine pathology or say an extra cardiac vascular malformation like Abernathy malformation, or some other non-cardiac cause of hypertension, pulmonary hypertension should be ruled out. And the moment your pulmonary vascular resistance exceeds somewhere around 3, you're uncomfortable. But if you really want to stage forward to a Fontaine, the only thing that at present what we can do is to add a fenestration to the Fontaine circuit. Is that okay? Yeah.
Yes, thank you.
Yeah. So if I can take this discussion forward, Abdullah, what you discussed today was, the management of a neonate born with critical heart disease. So if you look at the congenital heart disease as a whole, 25% of children born with congenital heart disease, 25%, that is 1 in 4 children are born with critical heart disease. So that's rather than traditionally classifying children into cyanotic and acyanotic heart diseases. Now, as we have progressed with neonatal cardiac surgery, the wiser thing is to classify them into critical heart disease and the simple heart diseases. So critical congenital heart diseases comprises 25%. And they are the ones that you listed there. That is the duct-dependent systemic, duct-dependent pulmonary, the parallel circulations, TAPVDs, and coarctations. So these children need surgery within hours to days. And if you don't treat them within hours to days, previously they usually succumb. So if you see most of these children born with these critical heart diseases, 90% die before the end of first year. So that's why if you see a 3-year-old or a 4-year-old cyanotic kid, it's most likely to be a tetralogy, because all other diagnoses would have died before the age of 1 year. Almost 90% die. You take, for example, it's an easy way to say that in the exam. What's the natural history of TGA? You can boldly say 90% die at the end of first year. What's the natural history of truncus? 90% die at the end of first year. What is the natural history of tricuspid atresia? 90% die at the end of first year. So that's almost the natural history of this whole group of critical congenital heart diseases. So most of these kids are identified in the nursery, and it's usually identified by the pediatricians either due to persistent cyanosis or due to persistent tachypnea leading to cardiac failure. And as you said, a good echocardiography is the mainstay of the diagnosis of heart disease. Previously, we had a hyperoxia test and all those things. Most of that is now relegated to history. But nevertheless, in a situation where you don't have an echo, you can suspect a heart disease much more with just saturations, looking at the saturation in an X-ray. But mostly it's, as you said, it is the echocardiography, a good quality echocardiography, actually. And as you said, oxygen, delivery of oxygen to every cyanotic neonate. Oxygen is a friend for every other baby, but not for the baby with the heart disease. For the baby with the heart disease, oxygen is an enemy. And previously, before the start of prostaglandin therapy and balloon atrial septostomy, most of these kids needed urgent surgery, emergency surgery. They had to be shifted to a good center and they needed to do a surgery urgently. But with the start of prostaglandin therapy and balloon atrial septostomy, most of the kids can be staged for a few hours or at least sometimes a few days till the surgery can take place. So that's one of the most important things of this modern stabilization. But an exception to this rule is the total pulmonary anomalous venous drainage. That's a TAPVCs. TAPVCs, as of modern pediatric cardiac surgery, remains the only true surgical emergency. There's no medical thing that you can do to stabilize the patient. The only thing left is, you have to operate if it's obstructed. So if you're asked what is the true surgical emergency in pediatric critical care, cardiac critical care, it's only TAPVD. Every other thing can be stabilized either with prostaglandin or with balloon atrial septostomy. And one of the most important things is transport of these babies. In fact, if you look why many of these critically ill babies are lost, it's because of the transport. And it's usually either improper transport or a few concepts which are not correct during transport. One of the things is, one of the common issues that we as congenital heart surgeons face is the kids come with almost intubated, ventilated with very bad lungs. That's a usual common picture if you've experienced. The need for intubation as a prophylaxis is one practice that should be abandoned. The common concept is that if you start prostaglandin and if the patient goes into apnea, the patient may, you may have to intubate at all. There is actually there is no hard and fast rule like that. You need to actually start the prostaglandin, stabilize the patient, make sure the pulmonary blood flow is good, or the systemic flow is well established, the lactates are cleared, oxygenation is better. And then if the baby doesn't develop a apnea, you can boldly shift a patient without intubation actually. So that is one of the common issues that we face, an improper transport, because you have a well-stabilized kit in the peripheral center and you have a good center, but in between the transport is what with non-humidified ventilation, with improper FiO2 settings. Many kids come with severe lung injury or plugged tubes. These are common issues that needs to be tackled in the care of critical heart disease. And as you said, coming to prostaglandin, am I going too long? Is this okay?
We are okay, Doctor. You can.
Okay. So coming to prostaglandin, everybody, even surgeons, should know how. Yeah. Coming to prostaglandin, you should remember that everybody should know how to start a prostaglandin infusion, whether you're a surgeon, whether you're a pediatrician, or whoever it is. It's quite simple, actually. If you remember the rule of 15, it is simple. It's called the rule of 15, 1-5. So you just take the body weight of the patient, multiply it into 0.15, and that is the amount of prostaglandin to be dissolved in 1 ml. And if you start, that is to be dissolved in 50 ml syringe. Dissolve 0.15 into body weight and dissolve that in 50 ml syringe. 1 ml will give you 0.05 microgram per kg per minute. So that's, you need to start at a 0.5 milligram dose, 0.5 ml dose, and gradually step up. As the saturation improves, bring it down. And the apnea is a dose-dependent phenomenon. So make sure that you don't give a purge immediately in the beginning. You give you can, for the time being, you can give a bit of oxygen, stabilize, and then as the prostaglandin sets in, take off the oxygen. So most of the apneas occur due to a sudden purge during the start of prostaglandin infusion. And even if there is an apnea, most of them are transient, and the babies usually get adapted to it and they come out of it. So an elective need to intubate and ventilate just for prostaglandin therapy is not indicated. And leaving on too long a prostaglandin is just the right friend. You can't keep them too long, you can't keep it too short. So you keep it too long, as you said, there are a lot of adverse events. One of which you didn't mention is necrotizing enterocolitis and sepsis. So these are the two main worrying things for a surgeon. And the even more worrying thing is when you operate, the PDA becomes a buttery PDA. It becomes like butter. And too high prostaglandin for too long, the PDA, the moment you ligate the PDA, it's going to just rupture sometimes. So you should be more careful when ligating a prostaglandin maintained PDA. And the most important thing now is that several of these patients can go on to stage onto a cardiology side, with the advent of PDA stenting. You can actually do a couple of, most of these patients who previously required BT shunts or central shunts can now go on to have a PDA stent safely. Because moreover, we found that, the PDA stent mortality and the overall morbidity to the kids are much less with PDA stent, albeit the difference, the overall long-term PA growth and all are dubious. I mean, they're doubtful, but still the immediate mortality and the morbidity to children with PDA stents are less. So whenever the PDA is suitable for a PDA stent, we will refer the baby for a PDA stent, and if not, we take up for a BT shunt. So these are a few points that I wanted to contribute regarding critical heart disease in children. But I think for the routine evaluation of other kids, I think we should have another session, because you can incorporate a bit of echo, CT imaging, MRI imaging, and those are the imaging that are routine CAT studies. Those are the things. Most of these newborns don't need all that. They just need, what they need is a good echo and good stabilization. Okay, thank you. Any questions?
Thank you, Doc. Such beneficial really points.
Okay. Anything else? Anything else anybody would like to clarify about stabilization and management of critical heart disease? Some points I might have left out.
Yeah, thank you, Dr. Mati. I think everything is clear now. Thank you, Abdullah. So we'll have a quick 5 minutes break, and then we'll resume with the second session. Ahmed,
Hello.
you can start.
Okay. Thank you. Thank you, Luaya, and thank you, Abdul Malik, as well. I'd like to welcome Dr. Thomas again for joining us this lecture today and supervising. So, Bismillah ar-Rahman ar-Rahim, my topic is about cardiopulmonary bypass in pediatrics. I'd like to start by a brief history about the cardiopulmonary bypass machine as a pre-era of the cardiac pulmonary bypass. The cardiac surgery had begun slowly in 1940 with operation that could be done without the use of cardiopulmonary bypass, like closure of PDA, coarctation repair of blood shunt, and the mitral commissurectomy. By 1950, it became obvious to those interested in cardiac operation that a heart-lung machine would be required to deal with the majority of the congenital cardiac malformation and valvular heart disease as well. Between 1950 and 1955, there were 5 medical centers engaged in the development of the heart-lung machine, each with different idea of how it should be function. The first one was at the University of Toronto Medical School. Dr. William Master developed a heart-lung machine that used isolated monkey lungs as the oxygenator. In Detroit at Wayne State Medical School, Dr. Forrest Ductal enlisted the help of engineers from General Motors to develop a heart pump, which called the Ductal GMR, General Motor Research. It was said to look very much like an old Cadillac V12 engine. Dr. John Gibbon at Jefferson Medical College in Philadelphia had been working on this problem longer than anyone else, and his machine was used DeBakey roller pump and a film oxygenator. At the University of Minnesota Medical School, Dr. Clarence Dennis had developed a rotating disc oxygenator based on earlier design of Viking Borgic and Clarence Crawford. Also at Minnesota, Dr. Walton Lilly was poised to begin a clinical trial in which the oxygenator would be either the mother or father, which is known as the cross circulation from the fetus to the parents. Finally, at the Mayo Clinic, Dr. John Kirkland and his colleague were building a heart-lung machine based on Gibbon design. So approximately 18 patients was operated in each of the institutes. Only one survived, which was operated upon the machine of Dr. Gibbon. And this is the machine that was developed by the Mayo Institute with the Dr. Gibbon heart-lung machine as well. After that, as a cardiac surgery evolved from its shaky start, the technology shifted from a very complex machine to a more straightforward device designed to be managed by a full-time specialist, which are the perfusionists. As I said, the first successful open heart operation using the cardiopulmonary bypass was done by Dr. John Gibbon on May 6th of 1953. And the operation was a closure of an atrial septal defect. And here's the patient and Dr. John Gibbon. Moving to the cardiopulmonary bypass circuit, it's much looks like the adult one. There is no difference. So the venous drain from the right heart side to the venous reservoir, as well as the vent suction and the pump sucker. They all drain into the venous reservoir, the main pump to the oxygenator, and then as well heat and the oxygenator, and then back to the systemic circulation. The arterial pump is the heart of the heart-lung machine. It's classified as either roller or centrifugal head. Most pediatric perfusion practices utilize a roller head for the arterial pump. The advantages of roller head pump or the component of the roller is 2 rollers positioned on a rotating arms, like in this picture, which compresses the length of tubing to produce a forward flow in the counterclockwise. This action can produce hemolysis. of the blood and tubing debris, and the incidence of which increases with the time. So hence the use of roller pumps for a longer procedure is discouraged. The other pump is the centrifugal pump, oriented with the arterial outlet at the low position, and the inlet of the venous drain is always at the center of the device. The problem with this pump, they are afterload dependent. So if the patient's systemic vascular resistance increases, the cardiac output generated will drop unless the flow through the pump is increased. The advantages, the centrifugal pump may improve the platelet preservation, the renal function, and the neurological outcomes in longer cases. Here is the other comparison between the roller and the centrifugal. So the roller is afterload independent, no flow meter required for the pump. Disadvantages increase the blood trauma and tubing debris, and there is no backflow occurs. The centrifugal, they are afterload dependent, needs flow meter, decrease blood trauma and tubing debris. There is a possibility of retrograde flow if the pump is stopped. It's expensive, and it's lesser risk for air embolism than the roller pump. Also, the important one for the pediatric is the priming volume. Priming volume for the roller pump is less, while in the centrifugal, you may need a large volume. Cannula, they are made of polyvinyl chloride, the venous cannula and arterial cannula. Venous cannula, either a single stage cannula used during most open heart surgery. The two cannulae are inserted, or the other one is the two cannula are inserted into the superior vena cava and inferior vena cava and joined by a Y piece. Dual stage cannula, where a single cannula is inserted into the right atrium. The drainage through this cannula occurs either through gravity or the vacuum applied to the reservoir to suction the blood. Alternative site for cannulation, the femoral vein in minimally invasive or reduced surgeries. Vent is always required or sometimes required to drain the left side of the heart for decompression of the LV and draining through the bronchial and TBCM vein. Arterial cannula is usually inserted into the ascending aorta. Alternate sites include the femoral, innominate, or axillary artery in situations such as emergency, reduced surgery, or minimally invasive surgery. Priming the circuit may actually exceed, the priming volume for the pediatric may actually exceed the blood volume of the neonates by as much as 200 to 300% of the blood. While in the adult cardiopulmonary bypass, the priming volume accounts for only 25 to 33% of the blood. So for adult and adolescent, the extracorporeal circuit is primed with balanced and buffer electrolyte solution. Blood is rarely necessary unless the patient is anemic before surgery. The average priming volume for most neonatal circuit, including all components, is 300 to 400 ml. Even at this small volume, blood is often required to maintain adequate oxygen carrying capacity and to maintain the hematocrit rate above or equal 25%. The use of a smaller circuit size and thus prime volume is aimed at decreasing the hemodilution, which in theory will result in lower numbers of transfusion, decreased severity of the inflammatory response, and thus reduce the hospital costs related to improved outcomes. Oxygenator perform the gas exchange function of the lung, so they call the lung of the heart-lung machine. We have two types of oxygenator, the bubble oxygenator, which are largely of historical interest, and the membrane oxygenator. The membrane oxygenator consists of hollow microbores of polypropylene fiber, about 100 to 200 micrometer internal diameter, and the blood flows outside the fiber while gases passes inside the fiber. So there is separation of the blood and the gas phases. They have a lesser propensity for air embolism and give greater accuracy in blood gas control. The newer design of the membrane oxygenator have integrated filter to manage the emboli, and this making additional arterial filter unnecessary in the circuit. A heat exchanger is integrated with the oxygenator as well and placed proximal to it to reduce the release of gaseous emboli due to alteration in the temperature of the saturated blood. Reservoir, they collect the blood drained from the heart. They allow a passive removal of entrained venous air, along with the option of applying vacuum to assist the drainage. They integrate a separate cardiotomy and defoaming circuit to process suctioning blood from the field. When they are used, a safe level of blood in the reservoir is maintained to avoid any air entry into the arterial circuit. Tubing is an essential item for pediatric. The overall goals for tubing selection are to minimize sizes and reduce prime volume while assuring reasonable system pressure, so as not to damage the blood as well or increase the risk of tubing disconnect while on bypass. So we have a different category of the tubing according to the internal tube diameter. So we have 1/8 up to half, and here is the prime volume for each one. So 1/8 is the smaller tuber, and the largest is 1/2. The arterial cannula, the arterial inflow is provided most often with a single arterial cannula placed in the ascending aorta proximal to the innominate artery. There is an alternative arterial inflow, include the femoral artery cannulation for reoperation or double arterial cannulation for interrupted aortic arch, and ductus arteriosus, pulmonary artery cannulation for ascending aorta and aortic arch hypoplasia. The sizing of the arterial cannula is by their outer diameter, range from 6 to 24 French, to accommodate neonates to older adults. Arterial cannula commonly have a wire-wound bodies to resist kinking. Additional arterial cannula should not become too rigid during hypothermia, since this can be put under stress on the aortic wall. So here is an example of the arterial cannula that's used in pediatrics. This is Biomedicus 8 French arterial cannula, and the other one is the DLB 6 French. It is an example of the hospital for sick children about the choosing the sizes for the according to the patient weight. So neonates under age of 6, they are usually using the size of 8 French, and the arterial line should be quarter, and the drain the flow rate is 0.1 to 0.7 liter per minute. And as we go up for the weight of the patient, the size of the arterial cannula is increasing, while the same of the arterial tube is the quarter. Young adult, we are using 24 French for arterial cannulation and 3 out of 8 for the tubing. Venous cannula, the majority of adult cardiac procedures are extracardiac in nature, like coronary bypass graft, aortic valve replacement, and may be performed with only a single right arterial cannula for a venous drainage. But in contrast, most congenital heart operations are intracardiac. So venous drainage is typically provided with bicaval cannulation, which allows for a total cardiopulmonary bypass. Venous cannulas ideally have internal lumen that is large enough to handle the expected portion of the bypass flow diverted to the reservoir, while not having an external diameter that completely occlude the vessel. Venous cannula commonly have a side portholes in addition to the tip hole, which importantly affect the flow performance. Blocking these side ports by inserting too large a cannula can diminish flow performance and desired flow rates. For this reason, a metal and hard plastic tipped venous cannula are commonly used in pediatric settings, like this Medtronic DLB. The hospital for sick children, they proposed this example for the venous cannula. So they choose 12 French if we want a flow rate of 100 ml per minute. And they get a bigger sizes if they want a 6 liter per minute. So cardiopulmonary bypass in infants versus adults, we have to remember that the neonates and infants are not mini adults. They have immature organs, they have immature coagulation, and they have some characteristics that is different from the adults. They have a small circulating blood volume, higher oxygen consumption, reactive pulmonary vascular bed, and they have intra and extra cardiac shunting, altered thermoregulation, and poor tolerance for microemboli. Here is a table for differences between adult and pediatric cardiopulmonary bypass. In adult, they are usually rarely using the hypothermic temperature, while in pediatric, they are commonly used hypothermia, moderate hypothermia, 15 to 20 CS degree. Circulatory arrest, they are common in pediatric. The prime volume is much more in the, that dilatational effect of blood volume, it is higher in the pediatrics. The perfusion pressure is higher in the adult while is low in the pediatric. Myocardial protection is an important, especially during the cardiac surgery for pediatric, because the pediatric heart undergoing surgery will suffer more complex interventions with greater temperature fluctuations. They have immature metabolic capacity that in turn may affect the response to ischemia during the myocardial arrest. This immaturity leads to a more rapid accumulation of lactate, which result in aerial inhibited of glycolysis, which in turn result in decrease in the high energy phosphatase such as ATP. Decrease in ATP will also result in decreased ability of the sacroplasmic reticulum to take up the calcium. And the end result of all of this are earlier ischemic injury compared with the adults, and possibly explain why certain pediatric patients have increased morbidity and mortality post-op. Infants and children with chronic cyanosis as a result of inadequate pulmonary blood flow often have increased bronchial collateral flow. And this increased blood return to the left heart can result in insufficient myocardial protection by warming the heart and also washing out the cardioplegia. So intraoperative myocardial protection plays the most important part of the cardiopulmonary bypass management, and adequate cardioplegia, perfusion techniques, surgical precision, and anesthetic management also. Cardioplegia, the principle of the cardioplegia is the ability to produce a rapid cardiac arrest, hypothermia, metabolic substrate, and to obtain appropriate pH and membrane stabilization by adding magnesium and lidocaine as well. Example of cardioplegia, the crystalloid cardioplegia, include Del Nido, which are the favored at Boston Children's Hospital, and the St. Thomas solution. The Del Nido solution contains sodium of 153 millimole, potassium 24 millimole per liter, chloride of 132, and the calcium is low here in the Del Nido solution. It's only 0.4 millimole. And this is the difference between the Del Nido and the St. Thomas, the main difference, I mean. While in St. Thomas solution, the calcium is higher, 1.2 millimole. So in heart, receive non-coronary collateral blood flow via pericardial connection or with aortopulmonary collaterals, which will participate in washing out the cardioplegia, and intermittent doses of cardioplegia every 10 to 30 minutes is advisable. Although pediatric coronary vessels do not suffer from occlusive disease, there are certain pathological conditions where retrograde perfusion may be a better choice, like in case of severe aortic insufficiency, arterial switch operation, and severe ventricular and septal hypertrophy. Care must be taken not to perfuse the myocardium at too high pressure, as this may itself lead to myocardial and vascular endothelial cell damage, and increase the edema of the heart and decrease the ATP levels. A pressure of 30 to 50 millimeter mercury has been shown to be adequate in cardioplegia perfusion. The last factor for importance in this question is crystalloid versus blood cardioplegia, and the blood cardioplegia result in myocardial arrest in oxygenated state with no loss of ATP is better a choice in pediatric. An important tip that surgical techniques must be meticulous so as not to cause unnecessary trauma to myocardial tissue, which may result in global dysfunction, heart block, or coronary artery problems, like kinking or transection or even air embolism. The anticoagulation management of the extracorbial circuit, because the exposure of blood to the extracorbial circuit surface activate the clotting cascade. Without systemic anticoagulation, the patient's blood will clot and obstruct the oxygenator. Usually they use unfractionated heparin, the most common drug used, because it is simple to monitor with ACT and reversal with protamine sulfate. The initial dose for heparin is 300 to 400 units per kg, either given intravenous or directly into the right atrium prior to cannulation. The target ACT is greater than 400 seconds, and we have to monitor every 30 to 60 minutes on cardiopulmonary bypass. Heparin works by increasing the action of antithrombin 3, and inadequate anticoagulation with proper heparin dose may be a result of antithrombin deficiency. And this situation may be corrected by giving exogenous antithrombin 3 or fresh frozen plasma. After separation from cardiopulmonary bypass, the protamine sulfate is infused to bind and inactivate heparin, and reversing anticoagulation and facilitating the post-operative hemostasis. The empirical dose for protamine is 1 milligram for every 100 units of heparin. The protamine heparin complex can activate complement and stimulate mast cells to release histamine, and both can cause cardiac dysfunction and transient hypotension. This is the side effect of protamine infusion. In neonates and infants, this is usually reversible with simultaneous intravenous administration of calcium. Protamine alone can, however, also stimulate secretion of thromboxane A2 from the platelet and causing severe pulmonary vasoconstriction and systemic circulatory collapse. So while during protamine administration, the surgical team must be prepared to reharmonize and reinstitute the cardiopulmonary bypass in the event of dangerous hemodynamic instability. Flow rate and pressure. The neonates and infants require a higher flow rate, up to 150 to 200 ml per minute per kg, and to meet metabolic demands. Combined with adequate flow rate, maintaining the minimal perfusion pressure is crucial to protect vital organ system. The neonates and infants have compliant vascular beds and making them more flow than pressure dependent. Usually the flow of pediatric of 1.8 to 2.5 liter per minute per millimeter square are commonly used for infants and children and adults during mild to moderate systemic hypothermia. Low flow cardiopulmonary bypass in neonates and infants is conducted at temperature of 18 Celsius degree to 20. And flow rate may be also lower, 50 to 75 ml per kg per minute or approximately during deep hypothermia circulatory arrest. Near-infrared monitoring for regional cerebral tissue oxygen saturation is used by clinician as an adjunct to real-time arterial and venous blood gas values in an attempt to provide a safer blood flow rate during cardiopulmonary bypass. In this table, the cardiopulmonary bypass flow rate relative to the patient temperature. So as we go down up to 18, the flow rate is as much lower as 0.7. Hematocrit is also an important aspect in management of cardiopulmonary bypass in neonates. The appropriate level of hemoglobin must be maintained to provide adequate oxygen carrying capacity. Individual tolerance level dictate the need for transfusion and can be monitored by several methods, including the saturation of the venous blood, cerebral and regional oximetry, and cardiopulmonary bypass blood flow rates, and also MAP. As blood viscosity increases with cooling, blood flow through the microcirculation may be impaired, a phenomenon known as the sludging. Matching core temperature to hematocrit, which is 20% hematocrit at 20 Celsius degree, is an example. Is accepted practice to avoid sludging. And data in children suggests that sludging does not occur and that a higher hematocrit of approximately 30% carries more benefit during deep hypothermia. Systemic cooling during cardiac operation while on cardiopulmonary bypass decreases the metabolic activity and suppresses the oxygen demand, and this will allow a reduction of cardiopulmonary bypass blood flow rate without compromising oxygen delivery to the tissues. Systemic hypothermia reduces the whole body and cerebral oxygen consumption by 5% to 7% for each 1 Celsius degree decrease in the body temperature. The decreased flow may improve visualization of the operative field and enabling a safe and precise surgical repair. Systemic cooling also offered a safety margin in the event of an unanticipated intraoperative catastrophic event. So during the aortic cross-clamping, hypothermia also minimized the rewarming of the myocardium, providing additional myocardial protection during the ischemic period. And hypothermia in neonates and infants does, however, have postulated disadvantages like capillary leak, prolonged mechanical ventilation post-op, and renal impairment. So some prominent centers have advocated complex cardiac intervention at a near normothermia with high flow and high hematocrit. So hypothermia, we have moderate hypothermia 25 to 32 Celsius degree, deep hypothermia from 18 to 20 Celsius, and deep hypothermic circulatory arrest where circulation is shut down completely at 16 to 18. Deep hypothermia with reduced pump flow to as low as 25 to 50 ml per kg per minute will allow the surgeon to perform a corrective surgeries with only minimal return of blood to the surgical field, whilst at the same time maintaining the vital organ perfusion. The HCA is used for the repair of complex intracardiac lesion as well as reconstruction of the diseased aorta. So here is a proposed classification of pediatric perfusion according to the degree of hypothermia. So if we have an older children with simple cases, only normothermic perfusion can be applied to these patients. In case of repair of VSD, tetralogy of Fallot, or subaortic membrane, moderate hypothermic perfusion can be applied. In more complex surgery, we can go for profound hypothermia perfusion and even circulatory arrest if we are doing aortic arch repair. Neuro Protection is an important topic in the cardiopulmonary bypass in pediatric because cerebral tissue has a high metabolic oxygen demand. So at core temperature below 22, the cerebral autoregulation, which maintains the cerebral blood flow across the wide range, will be impaired. So cerebral monitoring is a useful tool to ensure adequate perfusion delivery for the brain. Monitoring cooling at multiple sites, including the nasopharyngeal, the bladder, the rectal, and even the blood, provides information that is useful in determining the flow rate on cardiopulmonary bypass in children. EEG monitoring may be used to measure adequate depth of the anesthesia, but using EEG as an endpoint for cooling is unreliable because EEG activity does not always become silent at a consistent body temperature. The near-infrared spectroscopy has become a useful non-invasive tool to monitor the cerebral and regional oxygen saturation in the brain. DHCA is a useful method to allow surgical repair in motionless and bloodless field. The patient temperature is gradually lowered to 18 to 20 Celsius degree using cardiopulmonary bypass over several minutes, and the perfusion is stopped and the patient's blood volume is drained into the venous reservoir. The cannula may be removed to improve visualization of the surgical fit. Indication for the deep hypothermic circulatory arrest may include correction of complex congenital system or pulmonary venous return anomalies, repair on the distal pulmonary arteries, the aortic arch, and even management without clamping of a heavily calcified aorta in young children. So as we said, the brain has the lowest tolerance to ischemia during deep hypothermic circulatory arrest. Inadequate cooling may lead to cerebral rewarming during DHCA, which may result in neurological injury. So there is comprehensive strategy for brain protection and bypass, like adequate perfusion pressure, adequate delivery of oxygen as measured by the venous oxygen saturation and ABG, limit the inflammatory response, ensure adequate anticoagulation, adequate cooling time for at least 20 minutes, and monitoring by the near-infrared spectroscopy. All of these will help in brain protection. So calling for 20 minutes or greater, in addition, backing the head and eyes during calling has the theoretical advantages of rapid and uniform calling to prevent rewarming during deep hypothermia. And it is crucial to limit the arrest period to the absolute shortest time required to achieve the surgical objective. In general, at 18 Celsius degree, it is not recommended to extend the interrupted period beyond more than 40 minutes. And some author believes the safest period for deep hypothermia circulatory arrest is no longer than 30 minutes. Strategies of intermittent or continuous regional cerebral perfusion have replaced the use of extended or uninterrupted DHCA at many centers. Weaning from cardiopulmonary bypass, we have several criteria must be fully filled before weaning the pediatric patient. The heart must regain the sufficient function to provide adequate cardiac output. The lungs must have satisfactory gas exchange prior to separation. Abnormalities corrected before weaning. Temporary pacing may be used to increase the slow heart rate. Inadequate cardiac contractility should be treated with anotropic agents by the anesthesia. If hypothermia was used during cardiopulmonary bypass, the patient should be fully rewarmed to a core temperature of greater than 35.5 Celsius degree. Blood gas also should be performed to normalize blood pH and correct any electrolyte imbalance. Hyperkalemia is uncommon in patients with normal renal function, but hypokalemia may need correction due to diuresis while on bypass. Ionized calcium may be low due to hemodilatation or transfusion of citrate-containing blood and may be easily corrected while on bypass. Hyperglycemia can be treated with insulin. Mild anemia is usually not a problem with normal LV function, but is not well tolerated with minimal cardiac reserve or in pediatric patients with significant left to right shunt and abnormal arterial oxygen saturation. So we have to give a blood. The lungs are inflated before separation from bypass to treat atelectasia. Impaired lung expansion suggests either bronchospasm, which can be treated with bronchodilators, or a mucus plug obstruction, which should be cleared with endotracheal suctioning. If the pleural space was violated during surgery, any residual fluid volume should be aspirated to facilitate lung expansion. Weaning from cardiopulmonary bypass is performed by partially occluding the venous line to leave volume in the heart. And this volume increase the preload, encourage ejection and transition from mechanical to physiological cardiac output. As more volume is left in the heart, the support is simultaneously decreased from the extracorporeal circulatory while assessing hemodynamic parameters. The process is continued until totally cardiac output is being entirely provided by the patient's own heart. After assessing adequate hemodynamic stability, the cannula may be removed and heparin reversed to achieve hemostasis. Prior to decannulation and reversal of anticoagulation, adequacy of the repair is confirmed in most centers by TEE and sometimes requires direct assessment of capillary pressures or shunt calculation by saturation measurement. There are several complications of the cardiopulmonary bypass that all major organ systems can be adversely affected by a period of the bypass. Excess hemodilation combined with hypothermia may cause coagulopathy and platelet dysfunction, which leading to post-operative bleeding requiring transfusion of clotting factor and platelets as well. Foreign surfaces activation stimulate the systemic inflammatory response that may result in capillary leak and increased tissue and organ edema. Pulmonary, renal, and hepatic dysfunction may prolong the recovery period, although these issues typically resolve shortly after cessation from the bypass. Brain tissue carries the largest risk for injury following bypass, and this is especially during the period of deep hypothermia circulatory arrest. So neurological symptoms are usually related to global cerebral ischemia or even inadequate perfusion. Seizures, although rare, are usually temporary and do not require long-term medical management. In conclusion, cardiopulmonary bypass has been used for more than 50 years to allow cardiac surgical repair for a myriad of people worldwide, improve the surgical techniques, the extracorporeal circuit miniaturization, coated tubing, and perfusion management techniques have all contributed to making the cardiopulmonary bypass safer and yielding consistent results. The addition of monitoring systems such as transesophageal echocardiography and the NERS has been invaluable in facilitating real-time response in the surgical correction of congenital heart disease. And thank you. So any question?
Thank you, Dr. Ahmed. Excellent presentation.
Thank you. Dr. Thomas, have you any to add anything?
He may be not around with the group.
Yeah.
You can see his name, but I'm not sure. He has some issue with the connection.
Hello, can you hear me now?
Yes, Dr. Thomas. Welcome.
Yeah. So thank you, Abdullah, for that elaborate set of slides. And thank you for touching on history and spending a few slides on history, which most people don't know. And I know there's no end to what we can talk with perfusion. So remember that as cardiac surgeons, even if you want to be an off-pump surgeon, there's no, we cannot have any excuse not to know the nitty-gritties of cardiopulmonary bypass. So this is a very important topic on which we should spend due time. So Ahmed, is it okay that you can start from your first slides? You can show the slides, yeah, and then I can just pass comments on a couple of slides because it's elaborate, and I'll end up skipping a couple of things. So an interesting thing for you to remember is that if you're asked a cutoff, since this is an exam going group, If you're asked the physiology of cardiopulmonary bypass, it's quite easy to remember. You just write on these 4 topics, CVTS. CVTS is, of course, cardiovascular thoracic surgery. So C, you talk on the circulatory aspects of cardiopulmonary bypass. V, the ventilation aspects of cardiopulmonary bypass. T, the temperature management. And S, the still heart. So this is the broad subheadings under which you group various aspects of cardiopulmonary bypass. So we can just put a bit of history also. I hope you all know that Gibbon, how he started. Gibbon should be called the father of cardiopulmonary bypass. I don't think, he's, even though others were in parallel, he's the one who put the most effort, and he got his idea because he saw a patient dying from pulmonary embolism. And I hope you know the story. He just imagined if he could just bypass the blood, he would be able to, remove the thrombus and then get the patient back to life. So his quest for that started from one single patient whom he had to sit with at night. And of course, the person who took open heart surgery, the father of modern cardiac surgery, is none other than Lillehei, and he needs a mention. And it's a paradox that there's no surgery mentioned in his name. So almost all the first of all the congenitals is what he did. He did a very interesting thing called the controlled cross circulation. It's not just cross circulation, it's controlled cross circulation. And if you want to read about it, there's a beautiful movie called, there's a beautiful book called The Maverick of the Heart. So it's a book on Lillehei, is both his cardiac and his extra cardiac life. So one of the interesting things to note that is he had excellent results. He operated, I think, 48 patients or something, and even the first patients continue to live today. And I mean, till recently, he had excellent results. Can anyone guess why he could have had such excellent results in an era where we still there was no blood gases? Blood gases used to take an hour, and was he because he was? People say he was, of course, a good surgeon. But apart from that, the most interesting thing is that the parent act as a natural rectifier. So if the baby developed any sort of acidosis or hypercarbia or hypoxia, it would automatically go to the parent's blood, and it would automatically get corrected. So the patients used to just get extubated within hours. Even as first ASD was extubated, VSD was extubated just 2 hours after surgery. So that is one of the interesting things to go back and learn about some things about history. So if you could progress to the next slide, roller pump. Yeah, this the basic, of course, the setup of cardiopulmonary bypass. We'll go on to these details. The next, the arterial pump. This was actually started you should know the difference between these two pumps basically. So the roller pump is an occlusive pump. As you, it just doesn't sense what is beyond it. If the cannula occludes, if you put a clamp ahead of the pump, what will happen? The boot will just, the line that is inside the roller pump is called the boot. So the boot will just explode. It will just burst open. So that is one of the problems with the roller pump. So you should always be aware that if you caused any obstruction distal to the roller pump, it just occludes. That's not the case with the centrifugal pump, where it's afterload independent. So dependent. So where even if you put a clamp distal to the pump will continue to rotate, but no blood flow will occur. So that's one of the major differences between these two pumps. One is occlusive and the other is non-occlusive. And the roller pump was, in fact, invented by Michael DeBakey. He used it when he went for the World War. He used a similar handheld pump for a rapid transfusion of blood into war victims, into soldiers. So when he came back, he adapted that pump to use as cardiac surgery for cardiac surgery. So the stroke volume of the roller pump is determined by the tubing, the cardiac output in the roller pump is determined by the stroke volume of the tubing into the RPM. So you can, that's how the pump automatically calculates. If you put a 3/8 tubing, so you should roughly know the tubing volumes. It's easy to remember. The largest tubing that you have is half. The largest tubing that you have is half, and roughly take it as 40 ml. And the smallest tubing you have is 1/8. It's 2.5. So if you take a look at it, it's 40. Half of it is 20. Almost, half of it, it's slightly less than that, is around 13. So half of it is around 10. This will come around 10, and then 5 and 2.5. So it just goes roughly in halves. That so the stroke volume of the pump is determined, the flow rate of the pump is determined by the stroke volume of the tubing into RPM. While in a centrifugal pump, the cardiac output is determined by a separate flow meter that you place upstream from the pump. And that is a separate Doppler flow meter that, detects the flow upstream. So everything depends on if the perfusionist sets the tubing size wrong in the boot, you'll have a different stroke volume. So these are some of the troubleshootings that can happen. Actually, you might find you go to a new center and every patient is having lactic acidemia, pressures are not right, and the flow rates, everybody says the flow rate is right, and then you realize that you put in the wrong tubing into the, plugged in the wrong tubing into the boot. So things can, these are one of the, so you should be able to troubleshoot perfusionists running the pump. So it's very important for that. So, okay, go ahead, next slide. Yeah, these are the differences. And centrifugal is now almost exclusively used for ECMO circuits. It's not routinely used in adult because in routine cardiac practice, because they have not shown clinically a major difference between these two. Though the biochemical and subtle parameters are always better with hemolytic parameters, inflammatory parameters are better with the centrifugal and coated circuits, but no real major clinical benefit has been proven. So that's why we still continue to use the roller pump, and almost nobody continues to use the roller pump for ECMO circuits. So it's centrifugal is ECMO usually. Venous cannula, the cannula. Now, pediatric cannulas are a different beast altogether. They are totally different cannulas. We've got two sets of cannulas. One is the Biomedicus range of cannulas that's made of the one on top. That's the, thank you, one on top. That's the Biomedicus cannula. It's previously all cannulas were made of PVC, but the Biomedicus is made of polyurethane. So it gives you a better ID, that's internal diameter to outer diameter ratio. So you get a much bigger flow rate with these top cannulas on the top. That's called Biomedicus cannulas. They are coated cannulas. That means they have an internal coating, either of heparin or phosphorylcholine or whatever coating that the companies have, and it's usually predominantly used for ECMO. These Biomedicus cannulas are used for ECMO. The down one that you see are the ones called the DLP cannulas, which we commonly use for routine cardiac operations. They start from size 6 and goes up to up to 18 and more than that actually. You know what? Do you know anybody? Does anybody know what's the full form of DLP? Anybody? Just to make the interaction, non-boring.
Actually, I didn't know.
Yeah, DLP. This was there's a great surgeon, guy named Albert D. Pacifico. He is one of the guys who invented. He's the guy who invented the right angle cannula, the metal cannula. Now the names of his 3 children were David, Linda, and Phillips. So that's why you get the DLP cannula. Okay. So these are the flow rates that you have now, and you have even a 6 French cannula for the DLP now. The DLP 6 French is not routinely used unless you want it for arch cannulation or something. And the arterial line connectors now come with even with 316 connectors now. So if you see the DLP cannula here, it is blue. There are these cannulas now that come with gray connectors. You can see that gray area. So if it is gray, that means the connector will be a 316 connector, 3x16. Okay, we call a 3x16 inch line or 316 line or a 1/4 line. So you should know the difference between that. If you, I mean, it's mostly into pediatric. Okay, let's go back to the old slides. Yeah, cannulae. Okay. What is the minimum weight for a baby to be put on femoral cannulation? Okay, remember it. It's 10 kilos. You don't use femoral cannulae for any child less than 10 kilos. You put a femoral line, you lose the limb. It's a medico-legal issue. You can put, if you want to cannulate the baby, put a carotid line. You can ligate the carotid, but you can't ligate the femoral. That's the funny part of pediatric circulation. And okay, we can go ahead with it. Go ahead. Next slide.
Priming.
Yeah, priming. See, now you should realize that the priming of children, previously the oxygenators were the main area where we got a lot of prime. But now the most of the prime, actually even almost 70% of the prime is in the tubings. So the most important way to reduce the priming volume is to reduce the tubing size. And one area which Ahmed didn't touch on is ultrafiltration. That's the bread and butter of pediatric, I mean, without which we can't work. So with the advent of ultrafiltration being used in pediatric, we are not that, very much critical on priming. We do consider, we don't want a lot of prime to be added. Definitely we try to reduce the prime, but then we don't cut prime to a level where we become uncomfortable running the pump with very low levels and very low threshold for air embolism. We don't do that. We are confident now because we have an ultrafiltration. We use the ultrafiltration through all stages of cardiopulmonary bypass. So even if we add a bit of volume, we filter it out using puff. Puff is prime ultrafiltration. We ultrafilter prime, and preferably now we all do a blood gas of the prime before we go on bypass. We make sure that it's as physiologic as possible before we go on bypass. So because of that, we don't suffer from the previous effects of hemodilution, which was the main killer in the previous era. Okay, so that's priming. Priming is now huge. There's another. It's almost standard. You don't use any lactated ringers because the lactate is. You don't use sodium chloride based priming because of the chloride load to the patient. The chloride load causes hypochloremic acidosis. You don't use ringer lactate priming now because of the lactate interferes with the lactate measurements, and possibly lactate itself may contribute to an acidotic phenomenon. And so we almost always use now plasmalite or plasmalite based solutions. That's where it's almost like a ringer lactate solution, but the lactate component is replaced with acetate component. So anything like plasmalite and all those solutions are now the typical solutions that we use for pediatric priming. And of course, all pediatric priming requires blood. Most of the cases now require blood, and we usually use packed cells. We don't use whole blood, but there are centers that insist on using whole blood because fresh blood means within 72 hours of collection, which provides more factors, and the RBCs are not become really old, and their oxygen carrying capacity, their 2,3-diphosphoglycerate concentration is higher, and they have a higher oxygen carrying capacity. So we prefer, when available, to use fresh whole blood, but if we don't have a fresh whole blood, we are okay with RBCs. We don't add plasma to a routine prime now. except for very deeply cyanotic kids and big kids where plasma would help replenish and maintain the oncotic pressure. Mostly we use a lot of albumin, and it's albumin, blood, and a plasma-like solution, and with some other additives like soda bicarb, heparin, calcium. So that's the basic thing. And moreover, when we do an ABG, we get a good idea how good the prime is. Okay, the next slide. Oxygenators. Oh my God. Oxygenators are a huge topic. As you said, now polypropylene oxygenators, they're out of the industry. They're a decade back, there were polypropylene oxygenators. There are no more polypropylene. It's all of them are polymethyl pentene oxygenators. They're called Pmp oxygenators. The advantage of this Pmp oxygenator is that if you saw you said that it's microporous polypropylene hollow fibers. So this micropore, the configuration of the modern oxygenator is called a microporous tubular oxygenators. So what they do is they take this, actually it developed from this dialysis membranes. So the dialysis membrane is nothing but a tubule, which it's a very thin tubule that you take and you process it in such a way, you stretch it in such a way that small holes form on the surface of these tubules. So inside you will pass gas and outside you will pass blood. So that's called the blood phase and the gas phase. It's important to know all these things because some of the basics, if you don't tackle, you can end up with major air embolism in the cardiac during the surgery. So these micro tubules have micropores on them. And it is these micropores that increase the efficiency of the gas exchange. So when you add blood and when the plasma proteins, when you start the circulation, what happens is the proteins in the blood come and seal these micropores. They seal these micropores, and through these micropores, the gas exchange takes place. So that is why these microtubule hollow fiber oxygenators have microporous hollow fiber oxygenators have a life. Most of them, their rated life is 6 hours, actually. So when you run them for 6 hours, these pores get clogged more and more and more, and then the efficiency of gas exchange reduces. So it is important to realize that as time goes, your oxygenator fails because of these microporous configuration. So why doesn't the ECMO oxygenator, it never fails. You can keep it for 14 days, 15 days. You can go, people have gone up to a month with ECMO oxygenator. So why doesn't an ECMO oxygenator fail like this? Now, the basic reason why it doesn't fail is it's because of the structure is different. It's actually there's no hollow, these micropores are in there. There are no micropores. It is a plain sheet through which the gas exchange can take place. So there is no real interaction. So one of the clinical things that can happen with what you call with this is on one side, remember you have a gas flow, and on the other side you have something, you have blood. Now imagine during the pump run, you obstruct the gas outflow. That means the gas is coming to the oxygenator and it's going out through an outlet. Imagine you obstruct the gas outflow. If you obstruct the gas outflow, what is going to happen? It's going to leak through these micropores. The gas is going to leak through these micropores and it's going to get into the blood phase. And when it gets into the blood phase, it's going to cause microembolism. So you can have a patient throwing, embolism for large quantities of air if your outflow from the oxygenator is occluded. So remember that. And that's why we always talk of keeping the gas flow to blood flow at a ratio of 1:1. Okay, so 1:1 means if you're giving a flow rate, pump blood flow rate of 3 liters per minute, you're going to keep a gas flow rate of 3 liters per minute. Because if you exceed 3 liters, there's a chance that you can push air through these micropores into the blood and cause air embolism. So, but all this has decreased with this PMP oxygenators, polymethylpentene oxygenators, and even ECMO uses now these polymethylpentene oxygenators. So the technology has changed a lot over the decade, and yeah, that's about oxygenators. Okay, so reservoir, you know what it is. It's got all the filters and all that. The tubings, as we saw, the tubings, you said the tubings are made of polyvinyl. That's true. The connectors are made of? They're made of polycarbonate. They're made of polycarbonate. And one important thing, very practical thing that you should remember from what we've learned in life is that you see those barbs that are there on the connectors. That is those small steps that you push the tubing through. Make sure that when you connect it, at least you pass your tubing at least one ratch high, because otherwise, during warming, the tubing expands and it can slip off. So that's a very practical thing. These are, of course, things that you should just roughly know. Okay, go ahead. Arterial cannulas, we saw, yeah. Yes. Venous cannulas, yes. Nothing much. The right angle is what is mostly used for pediatric. The top one that you see is again a Biomedicus venous cannula. How you differentiate it from the aortic cannula is that the aortic cannula has only one hole at the end, while the venous cannula has one hole in the end, and multiple holes up to that black area. And remember, it's made of polyurethane. So the significance of polyurethane, it's much more fragile than the polyvinyl. So if you are going to make a hard tie on it, on the cannula, if you're going to tie it very hard on the cannula, there is a risk of it rupturing. So make sure that it's a very thin wall thing. You don't injure the cannula. The cannula has to be maintained precious. These polyurethane cannulas, you should know it, but they're a blessing to use actually. Okay, go ahead. Yeah, as you said, a very, very, very relevant statement. They're not many adults, and never bring adult practices into, I don't know if there are any adult people around, but adult practices into pediatric just don't work. It's a totally different ball game altogether. So yeah, go ahead. Go ahead, Ahmed. Yeah, these are roughly the thing. Okay, so before we go on to myocardial protection, a very important thing to realize is the flow rates. So in circulation, the flow rate is, you should remember, up to 10 kilos. The problem with up to 10 kilos, we rely on body weight rather than on BSA, body surface area, because there is no reliable way to calculate the body surface area in children below 10 kilos. In fact, you don't use the Dubois formula. The Dubois formula, I hope you're familiar with the Dubois formula, which we all commonly use to calculate perfusion rates. But we don't use that. To calculate BSA in children, we use either a Haycock formula or some other formula. But we found that it's important to use the flow rate. So up to 3 kilograms, it's roughly 200 milligram per kilogram flow rate. And from there to up to 10 kilos is up to 150 milligram per kilogram body weight. So that's the 150 ml per kilogram per body weight. So those are the flow rates that you use up to 10 kilos. So that second landmark for 10 kilos. The one is the femoral cannula, and the other is the flow rates. Then, yeah, you can go back to that slide. Okay. Okay, so we've skipped from here to straight CVTS of the CVTS component. We have skipped to the still heart. So always remember that it's about, myocardial protection is about ATP. And myocardial protection is not just about what solution you give. All the solutions have been shown to provide equal rates. Just that Delnido is a bit more convenient because you need to just give it only once. But the whole idea of giving myocardial protection is you're making an organ ischemic. You're cutting off blood supply to an organ. Now, if you want to cut off blood supply to an organ, how can you prolong the ischemic period of the organ? So basically, if you think, it's like, I keep saying an example. It's like, there's a village in which a drought occurs, in a remote part of the area where a drought occurs, and each house has a well. Now, if you look, the people who are going to survive is the people who are using the well which has the highest amount of water at the onset of drought, isn't it? You got my idea? So yeah, so it's like that. So if you are making your heart ischemic, if you're cutting off your blood supply to your heart, if at the onset of ischemia, if you have very high levels of ATP in your heart will survive the ischemic period. So because ATP is needed for two functions in the heart. One is for the beating of the heart, and one is the basic functions of the cell. The basic functions of the cell, to maintain cellular integrity, to maintain the sodium transporter function, to maintain calcium transporter function, to maintain the DNA, and all these things, you need the base level ATP. So that's, you divide ATP into the work ATP needed and the ATP that is needed for the basic housekeeping function. That's called the housekeeping function, the basic life of maintaining the basic life of the cell. So if you are able to build up a very high levels of ATP just at the onset of ischemia, then the heart will be in a better shape. So that's all your aim of that's the key aim of myocardial protection. So if you look at Comprehensive Myocardial Protection by Gerald Buchberg, has anyone read through that? Buchberg's ideas of comprehensive myocardial protection. Anyone? And tell me when it gets too boring. Yeah? Okay, so Buchberg's idea states that when you have a heart and you want to build up the ATP stores, especially imagine you're taking up a heart in cardiac failure or a heart who has an arrested heart. So already the ATP will be depleted in these myocardium. So you want to build up a good store. So he says, the first way to do it is give a warm induction. So when you arrest the heart, make sure that you give a warm cardioplegia. If you give a warm cardioplegia, the advantage is the heart stops beating, but it still remains perfused. So when it remains perfused, it has the myocardium will start building up the ATP, so that at the onset, when you start giving your cold blood cardioplegia, the myocardium will have already high levels of ATP. So that is a way to start. I mean, that's you get ideas from that. You don't actually do Buchberg's cardioplegia in pediatric. It's mostly in adult, the comprehensive myocardial management, like in cardiac failure and in severe aortic regurgitation, very dilated hearts. So the key idea is to, as I said, to maintain ATP stores. So one way to avoid depletion of ATP stores is this pre-operative, pre-bypass tachycardia that you see, pre-bypass tachycardia, pre-bypass use of inotropes. So if you tend to use high inotropes during the pre-bypass period, or if you are in an intense tachycardic phase during pre-bypass period, then you realize that your ATP is being used up heavily by the myocardium. So at the onset of your arrest, your myocardium will definitely have less ATP to start off with, and thereby when the ATP gets depleted completely, the myocardium goes into contracture. Actually, if you remember the basic cycles, you'll know that ATP is what is needed for relaxation of the muscle. So if the ATP is depleted, it goes into contracture, and that's called the stone heart. If you felt it once, where you put your hand into the thing to de-air, into the pericardial cavity to de-air, and then you realize the heart is like, it's like a cricket ball, and then you realize that's it, it's done, it'll never come back. Stone hearts never come back. So get this whole idea of managing myocardium with ATP. You want to give it ATP. So one of the advantages, we can go on talking about cardioplegia. If you want, you can keep a separate session on that some other day. So, okay, go ahead, the next slide. Yeah, the second form of important thing of cardioplegia is hypothermia. There are three components you should remember that cardioplegia has, especially in pediatric. One is the cardioplegia solution. The second is hypothermia. Hypothermia is very important in pediatric myocardium. In adult myocardium, whether it's that important, we're not sure, but nevertheless, whenever an organ is being made ischemic, you provide it with hypothermia, because basically the metabolic rate reduces. And the problem with pediatric myocardial hypothermia is that there is a constant rewarming of the myocardium. So there are several ways that the myocardium can rewarm, that you should be aware of that. One is the ambient lighting. So your theater lighting, if previously we had these lamps which are infrared generating lamps. So your theater temperature is a very important aspect of warming. And what happens is it warms the RV basically. And if you are using, as you said, most of us now we operate with temperature of mild hypothermia, even just moderate hypothermia at the most. We never go to deep hypothermia, very rarely now. So it is important to realize that your
No sound.
Dr. Thomas?
So it may take days out of this detailed discussions, and it's very important that that's how you get your information, by joining a surgeon and discussing all these details as you go day in and day out. Whenever you do a rotation, and try to be aware of the circumstances that happen with the cardiopulmonary bypass and with the cardioplegia and so on and so forth. I'm not sure if they're connected back in yet.
Yeah, he is with us, but I'm not sure. Okay. Dr. Thomas, can you hear us?
Yeah, I'm back. I got connected back. Yeah, please do tell me if I'm going on too long, because I thought I'll use this opportunity to tell you as much as I can. You can record it and, keep it for later.
We are enjoying that. You can keep on. We have all the time.
Okay.
Thank you.
Okay, thank you. Yeah. And the third most important thing, as we said, is hypothermia. One of the factors you should realize is if you use a single cannula on bypass, you should realize that the base of the heart gets warm, because the warm blood comes to the RA, the right atrium, and then it gets sucked out through the single cannula. So by the time it comes to the base of the heart starts rewarming, because you're using a warm perfusion strategy. So it is important that when you combine a warm perfusion strategy with it's possibly better that you do a bicaval cannulation. So when you do a bicaval cannulation, you'll keep the warm blood out of the field, and your rewarming, the accidental rewarming, is reduced. So they have put probes into the septal myocardium and monitored the temperature, and they've realized that as soon after the cardioplegia, your cardioplegia, you usually give it at a temperature of 8 to 12 degrees centigrade, and by the time the onset of cardioplegia, your septal myocardial temperature is usually in the early teens, like 13, 14. And as time goes, like, over 40 to 45 minutes, your temperature goes up. With the perfect of situations, your temperature goes up to late teens, like 19, 20. So if at any point of time you're going to add some, source of heat into the myocardium, your temperature will easily exceed 25 degrees centigrade, thereby, taking away the benefits of hypothermia. So it's always important to realize that how well you would like to keep your heart cold. So the way we keep it cold is by giving a cold cardioplegia and addition of topical ice slush. Now, this topical ice slush, the disadvantage is that prolonged topical ice slush contacts leads to phrenic nerve injury and possibly a bit of myocardial injury. But nevertheless, most people are of the opinion that you should use at least cold topical saline to keep the myocardium cold. A third most important thing about myocardial protection, which we fail to appreciate or which we don't take into consideration, is the LV distension. So unlike, very few situations in the adult, pediatric perfusion, we are always have a chance. We have a lot of shunts, we have a lot of aortopulmonary collaterals, we have PDA, the lurking PDA, and all these things which can suddenly lead to an over distension of LV. So it is always important to make sure that when you're giving your cardioplegia, you have an eye on the LV and your left ventricle isn't distending, because the moment left ventricle distends, your endocardial perfusion reduces. So either you have a vent to suck out all the increased return that's coming to the LA, or you make sure that you deliver the cardioplegia in such a way to prevent LV distension. And you mentioned about retrograde. I'm not sure if anybody uses a retrograde diuretic for arterial switch or anything, but most pediatric cardiac surgeons, I think they're almost all antigrade, and there's no role for retrograde in small babies, but maybe in a severe aortic regurgitation and situations like that, retrograde is useful. And yeah, as you said, the importance of ATP can never be overemphasized. Okay, go ahead. Yeah, correct. Okay, go ahead. Yeah, anticoagulation in children, you need to remember, it's almost same as the adult after 6 months of life, but up to 6 months of life, we have an issue. The antithrombin levels in neonates and up to 6 months is depressed. Children are born with almost only 50% of the antithrombin 3 levels. That's why you need to give a higher dose of heparin. The dose of heparin standard for neonates is 400 micrograms, not 300 as an adult. We need to give a higher dose of heparin and make sure that the ACT is in a higher range, because we've always found that in studies, we found that, whenever you run after a cardiopulmonary bypass, the thrombin generation, that means the activation of the coagulation cascade, is much higher in neonates. That's why they have this DIC phenomenon in neonates, in spite of adequate heparinization. So even with full dose heparinization, we found that the coagulation consumptive coagulopathy takes place because of the low levels of antithrombin 3. And antithrombin 3 levels rise to normal levels by 6 months. So up to 6 months, you need to be very sure that you're going on the appropriate doses of heparin. and protamine reversal, of course. And the bleeding, as you know, is a big problem in neonates after surgery, and that's multifactorial. And one of the things is a multi-pronged approach. You need to protamine alone will not achieve hemostasis for you, unlike adult practice. You need an antifibrinolytic, you'll need products and everything to achieve hemostasis. Okay, go ahead. Flow rates, as we said, yes, those are the flow rates. Go ahead. Yeah, hematocrit. This is a very important thing. Previously, the teaching was that you take your hematocrit just below the temperature that you intend to cool. If you intend to cool to 24 degrees centigrade, make sure your hematocrit is below 24 degrees centigrade. Anyway, now modern perfusion practice has no role for any hematocrit below 30 degrees, 30%. That's 10 hemoglobin is the base hemoglobin that you need to maintain whatever temperature you're going. You're going to TCA, doesn't matter. You maintain 10 hemoglobin. So it's always been a higher trend over the last 20 years. One person by name Mark Ranucci, he's been the one who's been doing all the studies on hematocrits, and he's realized that the moment you lower the hematocrits, the higher the incidence of renal dysfunction. So in neonatal practice, it's gone one step ahead. We now want a hematocrit of somewhere around 36 or 34, 36. That's around 12 hemoglobin. We run our pumps mostly now with neonatal circuits on 12 hemoglobin. And these days, as you said, we don't really go for TCA. TCA is very less. So we tend to maintain higher hematocrits. This old rule of the hematocrit below the temperature doesn't hold anymore. We don't use it anymore in practice. The moment you dilute that much, the patient develops all the problems of dilutional coagulopathy and oncotic pressure and fluid load and all that. So it's no more applicable. Okay, go ahead. Yeah, hypothermia, we know what the hypothermia is. So if you look into the history of cardiopulmonary bypass, we always say it is 3H, that H, the word H, that the alphabet H that made the cardiopulmonary bypass possible. One is heparin, the other is hypothermia, and the other is hemodilution. So these were the three things that made cardiopulmonary bypass possible. But in the modern era, these things like hypothermia is a good thing, but it's to be used judiciously. It all comes from the old, there was a trial conducted long ago called the Boston Circulatory Arrest Trial, where it's a very interesting trial, which you should know as a pediatrician, as a cardiac surgeon as such, because they've followed up children who have undergone TCA versus a low flow hypothermic flow for over a period of 40 years. 40 years, so right from the time they were neonates till now, they are adults. And they have found that those who have undergone TCA, total circulatory arrest, have always had evidence of neurocognitive issues. And even late into their 40s, there's almost a 30 to 40% incidence. In fact, they say higher incidence of neuropsychiatric disorders in people who have undergone TCA. So TCA per se is now used previously in art surgeries, we used to use it, but now it's almost exclusively into antegrade cerebral perfusion, where we cannulate the right innominate artery using a small cannula. And when we need to do the arch, we go down to 24 degrees centigrade, and we clamp off the cerebral vessels. We clamp the right innominate and the left carotid, and continue perfusing the brain, the upper brain and the upper limbs. At usually there's a wide range of rates, but a minimum of 40 ml per kg. So that's called antegrade cerebral perfusion. It's still one of the techniques that's being extensively fine-tuned, but previously what we used to use DHCA for, it's almost not being used now for. We use it very rarely now. Almost always the indication is very less. Like the last one I used was I was doing a TAPVC, and even with low flow rates, the field was not dry. So just to make the field dry, we had to use it. But almost always we go on wherever we need to use TCA, we use ACP now. ACP is antegrade cerebral perfusion at 40 ml per kg at 24 degrees centigrade. That's the safe limit. There are people who go from 20 ml per kg to 110 ml per kg. But now with addition of near infrared spectroscopy, we are able to get a more tailored flow for the patient. Okay. So DHCA per se is, as you said, we're not using it. So the cooling part is very important. So you need to know that there's a lot of the two phases. One is the cooling phase and the rewarming phase. So cooling phase, we say we keep a gradient of 10 degrees centigrade. So which means you keep the water bath, that is the water bath of the CPB machine 10 degrees lower than the patient's temperature. So that is the safest acceptable limit for cooling. So why 10 is accepted? If you cool faster, what happens is, you should always know that. So people are now cooling also slower, not even with the 10 gradient, 10 degrees centigrade gradient. I hope you are catching what I'm saying, because I don't know, there might be a whole group of people who are exposed at various levels. I hope you're getting it. So if you pass in a very cold blood into a warm body, what is going to happen is the gases that dissolved into the cold blood are going to come into the body which is warm, and the gases are going to dissolve out. They're going to come out of the gas dissolve phase, and they're going to cause microemboli in the warm body. So remember that even during cooling, you can actually develop emboli in the body. So it is important that you don't cool very rapidly. Sometimes, you see people who are urgent, come on, cool fast. No, there's no need for that, because and they say rewarm very slowly, because when you rewarm is when microbubbles form. Actually, when you rewarm, the microbubbles form in the oxygenator, because you're passing cold blood into a warm oxygenator. So that's where the microbubbles form. That's actually less dangerous than forming microbubbles in the body, actually. So cooling is also a phase where you go slowly, because when you cool rapidly, the major disadvantage with cooling rapidly is not this microbubbles, actually. It's inhomogeneous cooling. That's parts of the brain or parts of the body, they get cooled in different temperatures. So some part of the brain which has a high blood flow will cool to a low level, while parts of the blood flow where it's vasoconstricted will remain warm. So you will always have this inhomogeneous cooling of the brain when you cool rapidly. So that's why we add two safeguards to core cooling. One is topical ice on the head. So that is a safeguard that allows people have definitely shown that topical ice reduces the brain temperature. So you can add topical ice. And a very important thing is to give thiopentone. If you don't give thiopentone during DHCA, the neural outcome, it is the only drug that has been proven beneficial for TCA. So when you give thiopentone, the parts of the brain that are still warm, they also go down. So they also get suppressed metabolically, and they are protected better. So whenever, if you have the luxury to use an EEG during rewarming, you'll always note that the moment you give thiopentone, the EEG electrosilence is obtained better. So one area which we have not touched today is the pH stat and alpha stat strategy, but I'll leave it maybe we can take it on another day. It will be a overload for today. And ultrafiltration. These are the two things that we'll keep for. Okay, so yeah, this is basically the basic levels. Most of the children now, even if you're doing an arterial switch, now we still do it at 32 degrees or max 30 degrees. We don't really believe in making the body suffer a bout of hypothermia for myocardial protection. Our myocardial protection strategies are good, and our pump flow strategies are good now. So we don't really do circulatory arrest for every kid. It's only for the arches and Norwoods that we go, and that too we maintain on antegrade cerebral perfusion, as you said. Yeah, Neuro Protection. Neuro Protection, of course, is again, if you ever have to talk about Neuro Protection, always remember about a word called autoregulation. So autoregulation is a way, a brain has a way of regulating its own blood flow in spite of varied pressures. So even from a pressure as low as 40 to as high as 110, the brain controls its blood flow. The blood flow to the brain is almost constant. It doesn't matter what the pressure is. That's called autoregulation. The brain is the best organ for that. But the moment you induce hypothermia into the factor, the brain anything below 24 degrees, the brain autoregulation fails. So then your flow to the brain depends linearly dependent on pressure. So if you increase your pressure, your flow increases. If from 30 to 60, yes, the flow immediately doubles. So that's what happens. That's the effect of hypothermia on autoregulation. And the most important thing is, preventing hyperthermia is a very key factor in preventing brain injury, because you should remember that your nasopharyngeal temperature may be showing 36 degrees or your rectal temperature may be showing 35 degrees, but the blood that is jetting out of your cannula is the water temperature that you have set at your perfusion site. So if your perfusion is set 40 degrees, your myocardium and your brain, which gets the immediate blood supply from the cannula, is being perfused at 40 degrees. So always remember that, mentally keep that thing in mind, that your brain and heart, they are always being perfused at higher temperatures. Okay, go ahead. Go ahead, Ahmed. Okay. As we said again, okay, go ahead. DHCA is less used. Okay. Yeah. Again, weaning from, I think most important thing is, there are a lot of aspects of weaning from bypass, not to push in a lot of inotropes, to get a relaxed heart, not to cause vasoconstriction. Yeah, a lot of, okay, heart rate. Yes, okay, go ahead. Yeah, one of the things in pediatric perfusion, when I saw calcium, is that you should know the difference between calcium metabolism in adults and calcium metabolism in pediatrics. The neonatal calcium metabolism is entirely different from that of adults, because if you see the myocardium in neonates, the sarcolemmal component, that's the sarcolemma. Sarcolemma is where the calcium are stored in the muscle. The sarcolemma is immature and it cannot store calcium. So adult myocardium stores calcium inside the sarcolemma, and whenever there is a need for contraction, the calcium just steps out of the sarcolemma and then goes back inside. But the pediatric myocardium is totally reliant on the plasma calcium. So your plasma calcium is your base inotrope. That's why we tend to use calcium as an inotrope in pediatrics. It's not used in adults, if you've noticed. So neonatal myocardium is entirely dependent on ionized calcium in the plasma and not in the sarcolemma. Okay. Go ahead. Okay, go ahead. Yeah, complications. Yes, of course. That's the pathophysiology of cardiopulmonary bypass. It's huge. It's just like what is happening in COVID. It's a massive systemic inflammatory response. And what we are aiming as in future and as we are constantly trying is to reduce this inflammatory response that occurs with CPB. We have got various strategies and we are using various ways to reduce this: better monitoring of the cardiopulmonary bypass, better oxygen delivery. See, there are a lot of things that cause this. One is the foreign contact. The other is the stress of surgery, the stress of anesthesia, the pain that is induced, the tissue trauma that is there during cardiac surgery. All these contribute to the systemic inflammatory response. And we really don't have any magic thing to shut this inflammatory response. In fact, you saw with COVID, we realized it's the inflammatory response that is the major killer. And we found that finally we are left still with steroid. And even in pediatric cardiac surgery, we are left with nothing else but steroid. And steroid has not been the most promising thing. It has shown some clinical benefit, but it's far from the true final answer to the systemic inflammatory response that we induce during cardiopulmonary bypass. Okay. Thank you. Anything else I missed? I mean, of course, there's a lot more to discuss, but okay. Another thing that some of the terms that you should know is, one is a sweep rate. What is a sweep rate? Okay, a sweep rate is the flow of gas that the perfusionist supplies to his oxygenator. So that's the term that is used. We call it the sweep rate. So he uses the perfusionist usually sends it using a blender. So he can control the sweep and he can control the FiO2. Yeah, that's the blender. It's a blender that is used, and he can control the total gas flow and he can control the FiO2. So by the total gas flow, we control the PCO2. So if we find this, you go on bypass and you find the PCO2 is way too low, you'll say decrease your sweep rate. Okay, you don't say gas flow rate, you say decrease your sweep rate. Or if you find that the CO2 return, imagine you start using CO2 in the field and you suck out too much CO2 into the reservoir, and imagine your PCO2 rises and you want to blow out some PCO2 from the cardiopulmonary bypass machine, you'll tell increase the sweep rate. And if your oxygenation is less, you increase the FiO2. Okay, so these two topics, the pH strategy and ultrafiltration. pH strategy, it requires a bit of explanation of basics. And ultrafiltration, of course, is a small topic. So if you guys still want to, sit ahead with this, you can go ahead. Otherwise, we can take it on another day. So what's it?
Thank you. Yeah, if you have something you can discuss, we have some time.
You have some time. Okay. Then one thing what we need to know is the ultrafiltration. It's essential in pediatrics. So it's basically nothing but filtration. Blood filtration is a very old strategy. So blood filtration comes from the idea of there are three methods of filtering blood. One is called the hemofiltration. Hemofiltration is you take blood and then you pass it on to a surface, and that surface absorbs the toxins or whatever you want and gives back the blood. That's called hemofiltration. It's not called ultrafiltration. It's called hemofiltration. The classical one is you can pass it through. There's an old technique of removing toxins passing it through activated charcoal. Now there is a new filter called the cytosorb. I don't know if you're aware of it. It's a new filter. People have been using it in COVID, where the blood is passed through a filter and it absorbs particular molecules by the phenomenon of adsorption and the rest of it. So you can filter out cytokines using the cytosorb technique, a cytosorb filter. So that's called hemofiltration. The other way of handling blood is ultrafiltration. Ultrafiltration is you pass it through a membrane. It's almost like like an oxygenator or like a hemodialysis filter. You pass it through that, and it's got pores of a particular size, and which permits molecules of dimension smaller than that to get filtered out. And so you just pass blood through it, and just based on the molecular size, the molecules are filtered out. So you lose, say, if it's 12,000 Daltons, all everything below that will be lost in that ultrafilter. Now, hemodialysis is a way of passing your blood on one side of a membrane and passing another solution on the other side of a membrane. And by the process of osmosis, you selectively pull out some components of the fluid, components from the blood. So this is a basic difference between a hemodialysis and an ultrafiltration. Why I'm telling you this is because we always hear, oh, potassium is high, keep filtering. No, potassium is high, it definitely reduces the total potassium, true. But ultrafiltration does not have an ability to selectively filter out potassium. No, or selectively filter out any molecule for that matter. It just filters out molecules of a particular size. That's it. With that, it will pull out all the molecules. So it will take out even your fentanyl, heparin, everything it will pull out. So that is one of your basics way. So the basic role of ultrafiltration is the control of hemodilution. So you should remember that. It's people have this belief, magical belief in removing inflammatory mediators and things like that. They have consistently shown that inflammatory mediators are removed, but they're not preferentially removed. They're just removed based on whatever concentration is there in the blood. And so that's why I say it's modified ultrafiltration and not magical ultrafiltration. So you should know the difference between the various ways the filter can be used. As we said once earlier, that it can be used as a prime ultrafiltration. So when we use prime ultrafiltration, we just filter the prime without connecting to the patient, and we idealize the prime. The next way it is commonly used is used as a cuff, which is called conventional ultrafiltration. Conventional ultrafiltration is when you just, during the rewarming phase, if you know that, in fact, all the inflammatory mediators and all the, the systemic inflammatory response starts to peak during the rewarming phase. So during that phase, you start using, whenever you add volume and you think you're hemodiluting too much, you can add you can start your filter and then remove the excess volume so as to maintain the hemoglobin and the oncotic pressure of the perfusate. So that's a conventional ultrafiltration. You just keep filtering it whenever you want. So what is Muff? That's one very important thing that you should know. It was a technique invented by, it was in UK, I think, by Martin Elliott and group, Gosh, Great Ormond Street. So what they used to do was, they used to connect, after coming off bypass, they will incorporate this filter and remove the volume. So the basic difference between cuff and muff is, in cuff, you are basically filtering this total circulating volume. That's the whole circulating volume, which includes the venous line, which includes the venous reservoir, the arterial filter, and up to the arterial inflow line. So the whole line, the whole circuit, the total circulation is being filtered. Now, there is a limit to which you can filter that, because this is such a large component that you're using. Now, modified ultrafiltration is at the end of the bypass, you change your circuit in such a way that the arterial, you take your inflow from the arterial cannula, and then it goes to the filter, and then it filters out using the arterial pressure. You can supplement it with a pump if you, which is commonly used, and then you infuse it back using a small line. So thereby the advantage is you start concentrating the patient volume. In the cuff, you're concentrating the total circulating volume, the total volume of this pump and the patient. While in muff, you are actually concentrating just the patient volume. So you get a much higher hematocrit rise after muff. That's why the initial people, when they were using muff, they found a much greater hemodynamic benefit of using muff, because they could achieve much higher hemo concentrations at the end of bypass. But now, with the current technology, with the current low flows and the low priming volumes, and the practice of having higher hematocrits on bypass has led to, almost a lot of people don't really now stick to muff. So they've realized that at the end of bypass, if you're able to maintain a higher hematocrit while you come off bypass by addition of blood, you get almost the same benefits of muff. So even the person who started muff, his name is he's a perfusion by name Naik. He himself has said, that in his latest presentation a couple of years ago, he was stating what is the role of muff. But nevertheless, it continues to be, even as of the recent survey, it's used in almost 75% of pediatric centers continue to use muff, and most people will continue to use it for a longer time. But nevertheless, ultrafiltration is sort of mandatory when you are dealing with pediatric. Okay. So that's ultrafiltration, a lot of surrounding thing. There's a lot of mystery surrounding ultrafiltration. So I just wanted to break that. Now, so pH strategy and alpha strategy, it comes from I can approach it from a very different point of view. But how would you basically implement it in your practice? If you look from that point, you'll basically understand the theory behind it. I don't know if it's too much of an overload for you people, so I don't want you to get information overloaded. Is it okay? Do you want to continue?
Yes, please, Defect, if you have time. Yeah, please continue. Thank you. Okay. So the basic thing that you need to understand about the blood gas machine, we'll start from the blood gas machine. So if you see, anyway, an interesting thing about the blood gas machine, it comes from the company called Radiometer. Have you noticed the ABG machine is called Radiometer? It's called Radiometer 800 or something. You should always think why Radiometer is manufacturing ABG machines. They were actually a radio company in Sweden. They were manufacturing radios and not ABG machines. So when they stepped into this ABG machines, they decided that, when the blood is to be measured, all blood will, whatever the blood you put into the machine, it will be heated to 37 degrees centigrade. And then it will be measured at 37 degrees centigrade. Whatever, even if you're taking a blood from a patient who is on TCA and who's at 18 degrees, and if you put it into the blood ABG machine, it will measure the temperature at 37 degrees. So is there a mismatch between, there is a mismatch actually. So if you take blood and if you cool it, you should remember the blood becomes more and more basic. It becomes, the pH actually rises. So if you take the same blood, I wanted to, just for this class, I wanted to do that. But when I went to our ABG machine was not calibrated for temperature. So in spite of lowering the input temperature, you have an option to type in the temperature what you're measuring. So when you measure the temperature, it's supposed to chart the pH from a nomogram, and it's supposed to put the pH higher. So if you can do it in your center also. You just take 5 cc blood, put it into the ABG machine, and then measure one at 37, one at 30, one at 24, and one at 80. And you'll see that when you take the blood gas from the lower temperatures, the pH will be like 7.56, 7.66. It will go up to 7.6 and all. So the basic question comes, which pH should you believe? Should you believe you take a blood gas from a patient who's at 20 degrees centigrade, and you take it to one ABG machine, type in the input temperature as 20 degrees, and you measure it. You get a pH of say 7.56, and you take this blood to another ABG machine, and then you just measure it at 37 degrees, and you get a pH of 7.38. Now you got two pHs. Now which pH should you believe? The temperature corrected or the temperature uncorrected? That's the basic question. So it is as simple as that. If you're going to use a temperature corrected system, if you're going to believe that the pH is 7.57, and if you're going to act on that, that means you're following a pH stat strategy. It's as simple as that. And if you're going to follow a temperature uncorrected version, that's 7.38, that means you're following an alpha stat strategy. So the basic temperature at which the pump should be run, the basic pH at which the pump should be run is 7.40. That's the midline between 7.35 and 7.45. So you should aim your pump for always 7.40. So now, if you're going to follow the pH stat strategy, that is, you get a pH of 7.56, and how do you will want to correct it back to 7.40, isn't it? You want to run the pump at 7.40, which is the ideal for a body. So how are you going to correct this 7.56 to 7.40? Now, the way to correct it is add carbon dioxide. You add carbon dioxide or decrease the sweep rate to such low levels, or you basically add carbon dioxide, because you decrease sweep rate to too low levels, your oxygenation also will be affected. So you decrease the flow rate, add carbon dioxide so as to make the temperature corrected pH as 7.40. Got it? I'm not sure. Does everybody follow it? At least if some people can respond, I can get an idea.
Yeah, we're following.
You're following. Okay, then. So you give a CO2, you add CO2 to this pH of 7.56 and correct it to 7.40. Now, in reality, your blood is actually becoming, if you take this blood now and measure it at 37 degrees, now the blood which is at 7.40, and if you measure it at 37 degrees, it's going to be somewhere between 7.0 or 7.1. It's going to be really acidotic blood. Now, what is the benefit of adding an acidotic blood like this and keeping the blood acidotic? Why do you want? The advantage is that if you have an acidotic blood, it produces vasodilatation. Now, the vasodilatation is most important for the brain. Always remember, CO2 produces vasodilatation in the systemic circuit, vasoconstriction in the pulmonary circuit. Oxygen produces systemic vasodilatation in the pulmonary circuit, systemic vasoconstriction in the systemic circuit. Acidosis produces vasodilatation in the systemic circuit and as vasoconstriction in the pulmonary circuit. So pulmonary circuit, pulmonary vasculature and systemic vasculature behave diametrically opposite to these three factors: carbon dioxide, pH, and oxygen. They behave exactly opposite. So the advantage of providing carbon dioxide is that it actually makes your blood acidotic. But when you're looking at temperature corrected, it's normal. And it produces vasodilatation. So it produces a good blood supply to the brain. It prevents hypothermia induced vasoconstriction to the brain. So your brain has much larger blood supply, much more blood supply. It's called a luxurious blood supply to the brain. You provide it with luxurious blood supply to the brain. The advantage of providing luxurious blood flow to the brain is that the brain gets cooled much more homogeneously. So the downside that we said of rapid cooling, which is inhomogeneous brain cooling, is prevented by using a pH strategy. So when you use a pH strategy, the net effect is vasodilatation, producing a homogeneous cooling. So that is why when you go for TCA, the recommended strategy is to go for a pH stat during the cooling phase. And just before arrest, you switch to an alpha stat phase. Because when you switch to an alpha stat phase, what happens is you correct the acidosis that's happening there. The disadvantage with pH stat is that the enzymes, everything they get depressed in function because of this acidotic blood that's going inside. So just before TCA, you start TCA, switch to an alpha stat strategy, and then during rewarm on an alpha stat strategy. So this is considered the golden method of going on TCA. But nevertheless, now TCA is not of much use, but you should know what is this alpha stat and pH stat since you're going for exams at least. But it's better to approach it from the practical point of view rather than, from the theoretical aspects, which somehow never can get through into my head. So the temperature, the base thing is the temperature corrected pH. If you're using a temperature corrected pH, that's you go to the ABG machine and key in the temperature, you type in the temperature, and then you take a reading. And then you act according to it. You see that the blood is basic and you add acid to it, make it normal. That's called a pH stat strategy. I hope you got the idea. Okay, thank you. Anybody else would like to contribute that? If you have time, you can.
Thank you very much, Dr. Thomas, for your time and effort.
No, thank you. It was a pleasure.
So any question or comment before we conclude the session?
Thank you, Dr. Thomas. Appreciate.
Thank you.
So by this, we'll conclude our session for today. Thank you again, Dr. Thomas, Ahmed, and Abdullah for your presentations today. See you next time, inshallah.